So, ladies and gentlemen, it's a great pleasure to introduce Marit Kalisvaart from the Netherlands, our third-year resident, to talk about preoperative workup of HPB tumors. And the floor is yours.
Thank you. Good morning, everyone. Today I'll discuss the preoperative assessment of primary HPB malignancies. First of all, these are the Swiss numbers of HPV malignancies over the last years. First, as you can see, the pancreatic cancer, which is known to have a bad prognosis compared to other cancers. As you can see, the incidence of pancreatic cancer is 3% of the total cancers we have in Switzerland, but the cancer-related mortality is much higher with 7%. Then next we have the liver cancers with an incidence of 2% of the overall cancers and a cancer-related mortality of 4%. And last, cancer of the cholangiocarcinomas and the gallbladder cancers, which have an incidence and also cancer-related mortality around 1%. So the assessment of HPB tumors, you can assess them according to their anatomical location. First we have the intrahepatic lesions, we have the hilar lesions, then the extrahepatic biliary tree and gallbladder lesions, those tumors who will develop in the pancreatic head and the biliary cancers, and also the tumors of the pancreatic body and tail. So today we'll discuss tumors according to their anatomical location, tumor markers, and we also discuss the staging and assessment of three entities, the HCC in liver disease, pancreatic and ampullary cancers, and also hilar cholangiocarcinoma. So first, the intrahepatic lesions. Primary hepatic malignancy, the most common cancer is the hepatocellular carcinoma, or HCC. Then 9 out of 10 tumors are an HCC in the liver. And the second one is the intrahepatic cholangiocarcinoma. There are also a couple of rare tumors, but the most important thing is that you rule out that the liver lesion is actually metastatic disease of a non-hepatic primary, like colorectal metastasis. Then the pancreatic head and ampullary lesions. This series of Johns Hopkins from 2006 with 1,000 Whipple procedures has shown that most of the tumors in the pancreatic head that had a resection were pancreatic adenocarcinoma, followed by ampullary cancer and cholangiocarcinomas, but also these procedures were performed for benign diseases like chronic pancreatitis or intraductal papillary mucinous neoplasms, or IPMN. Then the pancreatic body and tail. Also here, the pancreatic adenocarcinoma is the most common tumor, followed by the IPMN and neuroendocrine tumors. Then the cholangiocarcinoma can actually develop in most of the HPB tract. So we've already discussed the cholangiocarcinoma in the liver, but most of the tumors actually will be hilar lesions, 2/3 of them, also known as the Klatskin tumors, and followed by 20 to 30% of the extrahepatic bile duct tumors. And furthermore, we also have the gallbladder cancers, which is actually worldwide the most common biliary tract tumor, not actually in Western Europe. So the assessment of HPB tumors, first the clinical presentation, is also depending on the anatomical location. Patient can present with abdominal pain, weight loss, but in case of biliary obstruction also with jaundice or pruritus. In rare cases, the patient will present with an acute abdomen, like in case of a bleeding of an HCC, or with cholangitis, but it can also be an incidental finding on imaging for other diseases. Then the signs of liver failure, portal hypertension are also important in case a patient also has cirrhosis. With most of the patients with an HCC will have that, and they can present with bleeding disorders or ascites. Then the tumor markers. Can anyone tell which tumor markers we use in the assessment of HPV tumors?
CA99.
Yeah, that's correct. Any other markers?
CEA.
And there's a third one.
AFP.
Yes, that's correct. And for the neuroendocrine tumors, we also have chromogranin A. To discuss a bit more about the tumor markers, we have AFP, which is used as a screening tool in combination with abdominal ultrasound in patients with liver disease. It has a high specificity but a low sensitivity. And also it's important that 30% of the patients with an active hepatitis will also have an increased AFP. Then the CA99 is mostly used in pancreatic adenocarcinoma. It's also a poor screening marker on its own, but it can be useful in follow-up after treatment. And also here, there's a risk of false positive results. And then the last one is CEA, which is mostly used in colorectal cancer, but in HPB tumors we see it that it's elevated in cholangiocarcinoma in a small portion of the patients. Also in pancreatic adenocarcinoma it can be elevated, but it has a low accuracy, and in HCC it's not used as a tumor marker. Then in neuroendocrine tumors we use the chromogranin A, also for non-functional tumors, but this test can also be false positive. And in functional tumors, there are numbers of tests depending on the hormone that a tumor is producing. So these tumor markers, on its own, they are not a good screening tool, but you can use them to assess the severity and advancement of the disease, and also on treatment effect and in follow-up. Then the first cancer we'll discuss is the HCC in liver disease. So HCC, how it can present is during routine screening, when we know a patient has a liver disease or cirrhosis. It can present in the further investigation of abdominal liver function test, can also be symptomatic with abdominal pain, or it can be an incidental finding on imaging for other condition. Actually, the patients that have an HCC in liver disease, only a small portion of the patients will be eligible for resection, because HCC most of the time is multifocal. In cirrhosis is actually a risk factor for complications, so these patients have a significant risk after surgery. And also oncological resections require wide margins, which you actually don't want to do because you want to preserve as much parenchyma as possible. And recurrence is likely with the cirrhosis persisting after the resection. So the first assessment is, as said before, the abdominal ultrasound in combination with AFP. It actually has a quite good identification of large tumors, but not in small tumors, and it's highly operator dependent. Then in HCC, do we actually need histology? The histological diagnosis remains the gold standard, but there's a risk of needle tract seeding, and these European guidelines from EASL actually show that if you have a lesion of more than 1 centimeter, you should perform a CT or an MRI. And if these imaging actually shows HCC imaging hallmarks, you don't have to do a biopsy, only if the diagnosis is uncertain. So it's only in selected cases. So the imaging that we do can be a CT or MRI. And what are the typical characteristics of an HCC on contrast imaging?
Arterial phase enhancement.
Yes, that's correct. And there's another.
Washout in the venous phase.
Yes, that's also correct. As you can see on this MRI image on the left side, there's the arterial enhancement of the tumor, and on the right side in the portal venous phase, there's already a washout is shown. Most of the centers first will perform a CT of the liver, which is more accurate than ultrasound, and you can also assess for extrahepatic disease with the thorax and full abdominal CT. But important here is that benign lesions can mimic an HCC, and therefore an MRI of the liver can be performed, which is actually the best study for differentiation from other lesions. So the EASL guidelines actually recommend that you do a multi-phase CT or MRI of the liver. The contrast enhanced ultrasound is another possibility, but it has a lower sensitivity than the CT and MRI, but you can use it as an additional test in case of an unconclusive previous imaging, and you could then also perform a biopsy. Of course, in these patients, it's also important to assess the severity of the liver disease. First, you have non-invasive testing, which are the laboratory tests. In imaging, you can see the appearance of the liver parenchyma and also signs of portal hypertension. A fibroscan can be performed, and also ICG for liver function. Invasive testing is, of course, the liver biopsy, and also if you want to assess portal hypertension, hepatic venous pressure gradient measurements can be performed, and a gastroscopy for viruses. Then in HCC, is there a role for the PET-CT? Well, it's not standard because there's only an uptake in less than 40% of the cases, but it is associated if there's uptake with a poor prognosis. And also the PET-CT has a high sensitivity for bone metastasis. The diagnostic laparoscopy, is there a role for that? Well, actually the guidelines recommend that you always aim to perform a non-invasive approach, because the patients normally will recover quicker after surgery, and it also avoids laparotomy in around half of the patients with unresectable disease. In most cancers, we use the TNM staging to stage the tumors, but in HCC, in liver disease, most centers will use the BCLC staging classification, which divides the tumor into 5 stages of very early stage and terminal stage. And as you can see only a small portion of the patients will actually be eligible for resection. They need to have a very early or early stage tumor with no macrovascular invasion on imaging, and then you have to identify the optimal surgical candidate with only mild liver disease, which not decompensated, no or mild portal hypertension. Also, there should be sufficient liver parenchyma remaining after the resection, and a minimally invasive approach should be possible. So then we'll discuss the pancreatic and periampullary tumors. The two resections that are mostly done in pancreatic cancer for the pancreatic head and ampulla is the Whipple procedure, and in the pancreatic body and tail tumors, the distal pancreatectomy and splenectomy in case of a malignancy. So the importance of vascular invasion in pancreatic cancer, can anyone answer the question which vascular structures might be involved in pancreatic tumors?
The superior mesenteric vessels.
That's correct. Both the superior mesenteric artery, as you can see in this image, but also the hepatic artery and celiac trunk, and venous or portovenous, it will be the superior mesenteric vein or portal vein. If these vessels are involved, there can be a locally advanced pancreatic cancer, which can be divided into a borderline resectable tumor or an unresectable locally advanced cancer. And if it's borderline resectable or unresectable, would actually be decided on the invasion of the SMV. The SMV can be involved, but only if there is an occlusion and there's no reconstruction possible. It will be an unresectable locally advanced tumor. In case of the SMA, if that's encased, if it's less than 180 degrees, there will still be an option to resect the tumor. If it's more than 180 degrees, it's unresectable. If it's then a locally advanced tumor, you could go for ablation or chemotherapy and then assess after the treatment if the tumor becomes resectable or not. So the imaging in pancreatic cancer, also here the first assessment is the transabdominal ultrasound. It's the first screening tool in patients with jaundice. It can also assess for gallstone disease and the level of obstruction of the biliary tree. It has a good accuracy, but only in large pancreatic tumors, and most of the time they're actually small, but you can see a double duct sign, which is shown here as well. Then the further assessment, the standard workup includes a triple phase CT scan with the arterial, parenchymal and portal phase. The first phase you can assess the involvement of the arteries. The parenchymal phase will show you a hypovascular tumor, and the portal phase the relation to the SMV. MRI is optional. You can perform an MRI liver if you have any suspicion of liver metastasis on the CT scan or ultrasound, and the pancreas MRI in case of cystic neoplasm and an uncertain diagnosis. Then the additional investigations, first the ERCP, that has been a diagnostic investigation in obstructive jaundice for years, but it is associated with a significant morbidity and mortality, and recently has been less frequently used due to the improvement of imaging studies. But it also has a role in biliary drainage. Do we actually have to drain the biliary tree before surgery? Well, a couple of trials over the last years, including this trial published in the New England Journal, has shown that it actually increases the risk of postoperative complications. The endoscopic ultrasound is now a new standard workup in the assessment of pancreatic cancer. It has the best accuracy for the detection of small tumors, less than 2 centimeters, and also vascular invasion. But it has a limited value to assess the involvement of lymph nodes. But it's also good to perform a fine needle biopsy when you have less risk of seeding. But also with this ultrasound investigation, it's strongly operator dependent. So then in pancreatic cancer, do we need histology in these tumors? Also here only in selected cases, because you can see if you have a suspicion of a pancreatic mass, you can do a CT scan. If it will show a resectable lesion without metastasis, you perform the ultrasound. And if it confirms resectability, no biopsy is needed. You can perform surgery immediately, but you could consider a biopsy in case of borderline or locally advanced tumors for your chemotherapy treatment. Then the role of a diagnostic laparoscopy, that can identify up to 30% of occult metastasis on the peritoneum or liver. And after a diagnostic laparoscopy, the resection rate is actually quite high, up to 90%, but the cost effectiveness of a regular use is discussed. So it's not the standard of care according to the European guidelines. Then the assessment of metastatic disease. The CT, which we already do for the local disease, is also standard workup for metastasis, but it has might miss small liver lesions or peritoneal mets, so a PET CT is also recommended in the standard workup for these patients. So then the last tumor we'll discuss is the hyalocholangiocarcinoma. The classic criteria for these tumors is the Bismuth-Collet criteria, which assesses the tumor according to the biliary tree. And we'll discuss newer staging systems later. Also here, the first assessment is the abdominal ultrasound for the biliary dilatation, level of obstruction, and also to exclude CBD stones. Then the resectability for hyalocholangiocarcinoma. The principles of resection here include that you would have to resect the involved intra- and extrahepatic bile ducts. Also should resect the associated hepatic lobes and the caudate lobe, because the duct of segment 1 or the caudate lobe actually most of the time drains closely to the liver hilum, so it is involved in high proportion of the patients. You should also resect involved artery and portal vein, and because the tumor, especially in type 3 and 4 tumors, it also is extending into the contralateral hepatic duct, and therefore an extended resection is often required, as shown here, where you do an extended right hepatectomy with an extrahepatic bile duct resection. Then the new staging systems for hyalocholangiocarcinoma also has been one developed here in Zurich, and this system does not only stages the tumor in according to the biliary tree anatomy, but also assesses the involvement of the vascular structure, including the portal vein and hepatic artery. We have seen that in 20 to 50% of the patients with a hyalocholangiocarcinoma are actually shown to be unresectable at the time of surgical exploration. So there's a large role for a diagnostic laparoscopy as well. In case you have a suspicion of an insufficient liver remnant volume before surgery, you could perform a portal vein embolization, which is shown in these images, where you embolize the portal vein on the site where you're going to resect, and this will promote growth of the future liver remnant. If this still remains unresectable, liver transplantation is an option in selected patients. So the imaging workup of the cholangiocarcinoma, an MRI of the liver and MRCP is part of the standard workup, because you have the best assessment of the local disease. It's non-invasive and also has a comparable detection to the ERCP for the detection of a hyelotumor. And you can also assess for the entire biliary tree, but also surrounding tissues like the vascular structures. The CT, thorax abdomen, is necessary for the local spread and metastatic disease. The role of the PET CT, it has been shown there's a high false positive rate in case of an inflammatory process of the biliary tree, but it's very sensitive for the identification of distant metastasis. So it's only used in selected cases. Then in hyalocholangiocarcinoma, do we need tissue diagnosis? These European guidelines actually state that if there's a focal stenotic lesion of the bile duct in the absence of any biliary surgery, an assumptive diagnosis of hyalocholangiocarcinoma is made until proven otherwise. And important, also a negative biopsy or cytology does not rule out a cholangiocarcinoma. So if you're still uncertain, like it can be a benign disease, like an inflammatory process like PSC or IgG4 disease, you could do a steroid trial or check for autoimmune markers. And then the last point of discussion is preoperative biliary drainage required of the future liver remnant. Most centers will perform it because it's been thought that drainage of the future liver remnant will reduce the jaundice and thereby improve liver function and also regeneration of the future liver remnant after resection. The question is, should it be performed endoscopically or percutaneous? And these two systematic reviews have shown that the ERCP actually is associated with more peri-procedural complications. But there has been a trial published last year. This is a Dutch trial published in the Lancet Gastroenterology and Hepatology. And in this trial was actually aborted early because they also compared PTC versus ERCP, and they had a higher all-cause mortality in PTC, which was not expected, but the authors also mentioned that there was actually a small sample size because it was aborted early, and in the ERCP group, half of the patients would still need a PTC. So they said that no conclusions can be drawn from this trial yet, and further studies are required. And it's also likely that it depends on the local service you have at your center for endoscopic or interventional radiology. So in conclusion, the preoperative assessment of primary HPV malignancy, well, the first assessment is actually always the abdominal ultrasound. Further imaging has been shown that MRI actually has the best detection and diagnosis of different tumors in liver and pancreas, but the CT scan is most widely used and also available, and it will also tell you the assessment of the distant metastasis, and there's an increasing role for the PET-CT in most tumors. Histology is not required in most cases, but you will need it if you have a locally advanced tumor and you would have to do neoadjuvant chemotherapy. And tumor markers are a poor screening tool independently, but can be used for follow-up and also prognosis. Thank you for your attention.
Yeah, thank you, Agrit, for this overview. A lot of topics that you have to cover in 20 minutes, so that's really a tour de force to go to all these different diseases while we could have an hour for each of these entities. So I don't know what comment to make. I think the very important today is still the anatomy. I mean, in liver, pancreas, as we have shown, it's very important to know the anatomy. If you go in this disease from any level, you would not understand what's going on, what type of surgery we are doing. So when we speak anatomy, you need to know then, and you presented that is the radiology. And that has been many changes over the past 20 years or 15 years. And the radiology is here to tell us what we need to know in terms of vascular invasion, location, etc. Of course, you need to know the anatomy. And one of the goals of good radiology is to avoid tests that are not necessary, like you've shown the biopsy. We see still today complication from biopsy, which could be dramatic, could lead to death, which are totally unnecessary. I mean, a patient with a liver mass who is cirrhotic with an alpha fetoprotein of 5,000, a biopsy is completely wrong. We know what that is at 99.9%, and that has risk of seeding, etc. So I think this is maybe the take-home message that I have for mostly what you say. And I think we have to say, I mean, here it's a large topic. Many people see many of these conditions, so it's okay if you have not seen and you have to see all this data. It's maybe a little bit too much. My last point here is, of course, the MDT or several people involved. You've shown we need ERCP, PTC, at some point neoadjuvant chemotherapy, surgery, etc. So this is really a disease. It's not unique in the HPV field where you need all the people on the table, including the surgeon. We see, and I think it's everywhere, still management where the surgeon is excluded from the beginning and then come later. I think this is wrong because you need, even if it's not initially a clear surgical case, you need a strategy to go to surgery, and surgeons must be involved from the beginning in most of these cases where there is a chance of a cure at the end of the day. So I think this is really specialized center. It's important for this. This is complex. We, all of us, a patient a day, we need to go in a place where we have expertise, so that must go in places when there is some expertise. It's sometimes even an advantage. A center has also transplantation. It's not absolutely necessary, but many of these diseases at the end of the day can be, transplant is an option. So this is, best treatment is in a place where they have many doctors, many field gastro, etc. on board, and if possible, transplantation.
I think the idea of this topic was to, get an overview, as many of our residents in the beginning are in our outpatient clinic, and most of the preoperative workup is done there, and should help them to, get into this field and know a little bit which are the main imaging procedures to be done. I think to make it very clear, if I talked a lot to Cecilia Reiner also, and I think for the HPV malignancies at the moment, if you can, you should always perform an MRI. There's much higher sensitivity and specificity, and you have in most or in a lot of cases you can detect also what kind of tumor you have, if it is adenoma, FNH, hemangioma, or if it's an HCC. So with the different contrast media, the MRI is best. And you have no restrictions regarding a lot of our patients. They have like a low or not a good kidney function, and in CT scan you always use nephrotoxic agencies to as contrast media, and this for MRI is not needed.
Yes, Mary, thank you very much. I have one comment. You said for most tumors you have an increasing role for the PET CT. But if we're here, we see pretty much every patient gets a PET CT. Is this, from what you've read over the last weeks, wrong? Or we just have enough money, we should do it? What do you think?
Well, for the pancreatic cancer, it should be the standard of care according also to the guidelines. For the HCC, it only has an uptake of 40%, so I wouldn't use it. And I think in hyalocholangiocarcinoma, we're about to do it in most patients. So selected cases.
It depends where you are and whether you have a PET CT. There are still many countries, including in Europe, when they have 2 or 3 PET CT for 1 million or more. So it depends whether you have that. And that comes to the other point, which I just want to make, is these guidelines. It's good to have guidelines, but they are not the Bible, whatever religion you have, that tell you what to do. We have to be very careful. These guidelines are an exercise that many like to do. The journals love to have it because they increase their impact factor. They are useful, but we should be very, very careful when we discuss. This is not only, we can discuss many things, and you show the PET scan in many of these. Here we did, when many years ago we had one of the first PET scan in the world. Memorial Sloan Kettering and Zurich had a PET scan. So when arrived here, I knew that there is a new tool that you can detect tumor outside of the place where the tumor is. Then we did the studies. We did study in pancreas, we studied in cholangiocarcinoma, I mean several diseases, colorectal metastasis at the beginning, and found indeed a number of cases that we changed the treatment because of the PET scan, because that's what you want to look at. Now, I don't know all the guidelines. For pancreas, is not done in many places, the PET scan. I think in France, if I'm correct, they don't do it, and they don't do PET scan. Colorectal metastasis either. So this is highly variable. I think we do it here, and I think it's maybe a good time now to have a large study that tell us today, with all the other tests, when do we change treatment with the PET scan? It was maybe different 20 years ago, but the other modality are better today, like MRE or etc. So I'm not totally convinced that we should do, maybe we do too many PET scan here. That's a bit my bias, and we need some data in this field. And come to my last point is radiology here. I think as surgeon involved, we must be demanding in radiology. We get X-rays sometimes. Whatever they are done, they are not acceptable, and we should not accept. I think the mistake is to go in surgery with pictures that are not of highest quality, whether it's MRCP, whether it's MR angio, etc. So we need to put some pressure, because we can get absolutely fantastic pictures who help a lot. So make a big difference when you look at the finding in surgery that you did not expect. In fact, often is associated with either a poor quality of radiology before, that we should not, or we did not look carefully enough before at the X-ray. So here, the detail and quality is also in the preparation of the patient for surgery.
Thank you very much. I just have a comment regarding MRIs. Would that not be a good indication for a PET MRI? Because clearly radiology is looking for indications for PET MRI, and it seems that that would maybe combine the best of both worlds.
Have you experience with PET MRI?
We don't have a lot of experience with PET MRIs, so I think for colorectal diseases it is not truly helpful.
I think I even believe we study. I mean, here they have a PET MRI not really on site that we can use. We were very interested, for example, in cholangio, because you know this tumor you see very well in the MRI, and the PET scan alone is not. Combining both could be useful to establish a positive diagnosis. I don't know. I must admit that I don't know convincing data so far about PET MRI for HPV disease. I don't know if someone knows. I mean, I don't know. Okay, thank you very much. Thank you.